Hello everyone, myself Dr.UMENDRA, consultant pediatrician, and in today's video we are going to discuss regarding another important general examination finding, that is clubbing. So let us discuss clubbing. So first we will discuss the definition. Clubbing is a bulbous enlargement of the distal portion of the terminal phalanx due to proliferation of sublingual connective tissue, and the term was first given by Hippocrates. It is called Hippocratic fingers or serpent's hand, as the first described by Hippocrates. Then coming to features of clubbing, the first important feature is fluctuation and softening of nail bed. Then there is obliteration of the Lowy bond angle, which is angle between the nail bed and proximal nail fold. So this is the Lowy bond angle, and it is in normal subject it is 160 degree. Then the third feature is Samroth sign or Samroth window test. When the dorsum side of the corresponding digits of opposite hands are placed opposite to each other so that the nails are in contact, a diamond shaped space is seen. This is the diamond shaped space seen in normal subject, and which is obliterated in case of a clubbed finger. And the fourth feature is increased convexity of nail in both vertical and transverse diameter. Then how to elicit clubbing? The patient's forefinger is held with both the thumbs. The examiner then places both his index finger on either side near the base of the patient nail, and pressure is then applied with one index finger, and the movement is felt by other finger. I will try to show it in the video. And in early stage of clubbing, fluctuation can be elicited at the base of the nail due to soft tissue proliferation. Then coming to certain examiners ask regarding the mechanism of clubbing. So there are different theories. First one is the anoxic hypothesis, where due to arterial hypoxemia, there is opening of arteriovenous anastomotic fistula, and this leads to overgrowth of the soft tissue, which is elicited as clubbing. Then the second one is the humoral theory, where unidentified humoral substances like bradykinin, growth hormone, parathyroid hormone, and estrogens, all these lead to dilatation of vessels of fingertips, and this leads to the hypertrophy of terminal phalanx. The other mechanism is reduced ferritin, which causes dilatation of arteriovenous anastomosis, and this again leads to dilation of vessels of fingertips and hypertrophy of terminal phalanx. Then another mechanism is vagal theory, and in this also there is vasodilatation and again dilatation of vessels of fingertips. So these are different mechanisms of clubbing. Now coming to what are the grades of clubbing? This is a fascinating question for examiner. So grade 1 is fluctuation and softening of nail bed. Grade 2 is obliteration of the nail bed angle, that is Samroth sign, which we have seen in the previous picture. And in normal subject, the Lowy bond angle is less than 165 degree, or most of the books write it to be 160 degree. Then grade 3, there is parrot beak appearance due to increased convexity of nail fold, and drumstick appearance due to thickening of the whole distal finger. You can remember it, grade 3. 3 in Hindi we call teen, and parrot we call tota. So 3 for tota, 3 for teen, and teen for tota. So parrot beak appearance in grade 3 clubbing. Now coming to grade 4, there is swelling of fingers in all dimensions associated with hypertrophic osteoarthropathy. Then what is the benefit of this elicitation of clubbing? As we all know that clubbing in itself is not a disease, it is manifestations of various diseases. So if it is lesser grade of clubbing, it may be due to fibrocaseous pulmonary tuberculosis. inflammatory bowel diseases, and polyposis of colon. And if it is a higher grade of clubbing, this may be due to cyanotic congenital heart disease, chronic suppurative lung diseases like emphysema and bronchiectasis. And hypertrophic osteoarthropathy can be seen in bronchiectasis, cirrhosis of liver, or mesothelioma. Then coming to types of clubbing. On the basis of duration of development of clubbing, it is discussed into divided into two broad categories. That is acute clubbing. It develops within 2 to 3 weeks of time span, and it is seen in suppurative lung disease like lung abscess. And in lung abscess, it may develop in 2 weeks time also. And the other causes are infective endocarditis and mesothelioma. Then coming to chronic clubbing, it develops in about 6 months to 1 year's duration, and it is seen in cyanotic heart disease like tetralogy of Fallot, in which case it develops within a duration of 6 months, and in many cases it first develops in grade 2, then in other digits. Then the other causes of chronic clubbing are bronchiectasis, arteriovenous malformations, thoracic outlet syndrome, and Pancoast tumor. Then coming to causes of unidigital clubbing. So sometimes this is asked that what are the causes of unidigital clubbing. So you can remember it by the mnemonic GST. You all are paying GST. So G for gout, S for sarcoidosis, and T for trauma. So these are the causes of unidigital clubbing. Then coming to causes of bilateral clubbing. So it may be due to primary causes and or maybe due to secondary causes. In primary, the subdivisions are idiopathic or familial. In some family, it runs throughout the different generation without any obvious symptoms. Then coming to secondary causes, in that in the cardiovascular system, cyanotic heart diseases are the most common. Then subacute bacterial endocarditis or chronic congestive cardiac failure may be the causes. Then in the respiratory category, we divide into suppurative causes and neoplastic causes. In suppurative causes, there is bronchiectasis, lung abscess, emphysema, and pulmonary TB. And in case of neoplastic causes, it may be due to bronchial adenoma, mesothelioma, and carcinoma lung in case of adult patients. Then coming to the abdominal causes, it may be due to cirrhosis of liver, malabsorption syndrome, intestinal polyp, and inflammatory bowel diseases like ulcerative colitis and Crohn's disease. Then coming to endocrinal causes, it may be due to myxedema or thyrotoxicosis. So now coming to the another terminology, what is differential clubbing? So if clubbing with cyanosis limited to lower limb, it is called differential clubbing, and it is seen in a case of patent ductus arteriosus with reversal of shunt. And clubbing with cyanosis limited to upper limb is seen as transposition of great vessels with patent ductus arteriosus with reverse shunt. So these are some terminologies sometimes asked by the examiner. Then coming to another important terminology, that is pseudo clubbing. What does it mean? So there is appearance of clubbing without it actually being present in the subject, and it may be due to hyperparathyroidism, Hansen disease, that is also called leprosy, and leukemia. So these are all important points which I have discussed regarding clubbing, which are important regarding clubbing from your examination point of view, and also in diagnosis of patient. Yesterday I met a patient. He is 40 years old, and he has been examined by some local practitioner and given some medicine for this breathlessness. And when I examined and see his clubbing and auscultation of the chest, I found that it is due to some cardiovascular causes. So I suggested him to meet a physician or cardiologist, and today I came to know that has been diagnosed as a chronic CCF case. So thank you. With that, I hope this will be helpful for you for your examination and for your practice. So if you like this video, kindly share with your friends and do comment if you want some other topic for video. So you can comment me and also give your advice. Thank you very much.